Good morning, everyone. Today is the 4th of December. I'd like to welcome everybody. I'm standing in for Dr. Godinho. I'd like to present Michelle. She's a qualified hematologist currently working at Ampath laboratory. She has an interest in coagulation as well as veterinary pathology. She attended University of Pretoria and obtained the following degree: BSc Human Physiology and Bachelor of Medicine and Surgery. She completed her internship and community service at Tembisa Hospital. In 2021, she completed her postgraduate studies in hematology at Sefako Makgatho Health Sciences. And she's also one of the founders of these podcast presentations and our weekly clinical meetings. And she'll be sharing our hematology committee. Dr. Michelle, the floor is yours.
Thank you, Emmanuel, and thank you for this opportunity. So today I'm going to talk about von Willebrand disease. Because this disease is so common, but it's also quite difficult or interesting to diagnose, I thought this will be a nice refresher for everyone. So as you know, I'm from Ampath, and today's presentation will mainly focus on these journals that I used as guidelines, as well as a recent journal for laboratory diagnosis of von Willebrand disease. This journal actually talked about a 4-step assay used to diagnose von Willebrand disease. As we know that von Willebrand disease has got a 3-test assay, and this is usually used to screen for von Willebrand disease. And at Ampath, we now implemented the collagen binding assay, and this is just to prevent misdiagnosis of von Willebrand disease and also increase the accuracy of the diagnosis. So the references will be at the end, but I've used these articles mainly in my presentation. So for the outline, I'm going to talk about what is von Willebrand disease as well as the factor. I'm going to talk about the structure of von Willebrand function. This is going to be quite interesting. It's a structure with a lot of binding points, and the mutation within these binding points will actually lead to von Willebrand disease. I'm going to talk about the classification. So this I'm going to try and, just make it straightforward, not to get too difficult or confuse people. What do we do, or how do we assess for von Willebrand disease? And then for interest's sake, I put in the principle of the test. So I know for all the physicians, they're going to get bored, but this is just a few slides just to say what we do in the lab and how we test. And then how we diagnose, the flow diagram, what we can use to follow to diagnose von Willebrand, and then at the end, my references. So this slide sums up the entire presentation. So what is von Willebrand disease? So first of all, if you're diagnosed with type 1, you've got decreased production in von Willebrand factor. So if you have a decrease in factor number, your function will be decreased in proportion. And that's how we diagnose type 1. In type 2, it's usually the function that's defective. So this will say the binding of a certain area in your von Willebrand factor has got a mutation leading to a quantitative deficiency of the von Willebrand. And then in type 3, your type 3 is actually almost absent, like an absent von Willebrand factor. And then you can see also with the type of treatment, with the type 1, we can actually use desmopressin or cryoprecipitate to treat. With type 2, it depends on what type of 2 you have, but that will also be usually with cryoprecipitate or factor 8 factor replacement. And then in factor 3, type 3, where there's about absent von Willebrand, remember with this, you can't use desmopressin because there's no von Willebrand factor to increase in this patient. So what is von Willebrand disease? Well, it's quite interesting, but this is the most commonly diagnosed inherited bleeding disorder. Most of these are inherited in an autosomal dominant way. It affects about 1 in 10,000 individuals. As you can see, it's quite prominent, and the incidence in males and females are equal. As you can see, it's not X-linked like a hemophilia type of disease, but it's common in males and females. So the diagnosis of von Willebrand disease is quite complex. And why is that? Because we need a family history of bleeding symptoms. Also, then we can see if there's a personal history of bleeding, and then we need confirmatory laboratory tests. And the classification of von Willebrand, it's currently based on the criteria developed by the von Willebrand Function Subcommittee, and this actually includes the International Society of Thrombosis and Hemostasis, as also the National Institute of National Heart and Lung and Blood Institute. So as you can see, there's an expert panel working on the diagnosis of von Willebrand disease. First of all, you know that patients with von Willebrand disease have reduced levels of von Willebrand factor, and this will actually cause decrease in the primary hemostasis. Because of the function of von Willebrand disease, it's usually got two main coagulative functions. First of all, it wants to bind to factor VIII and prolong the factor VIII half-life in the circulation. But then another important function is actually that it adheres the platelet to the endothelial cell, as also it actually assists with platelet aggregation. So as you can see, it's got a major function with adhesion to the endothelial wall, as well as to platelets. So this is why it's sometimes a platelet function test as a screening for von Willebrand disease, because you will detect that it's actually abnormal. But interesting, and that's just the picture to show that von Willebrand function is also very needed for platelet aggregation. And then interesting, there's a lot of research occurring. What other functions does von Willebrand have? Not only does it play a role in angiogenesis, because they've seen that patients with von Willebrand disease has got angiodysplasia, but it also has a role in vascular smooth muscle cell proliferation. It actually also inhibits osteoclastogenesis, and it also actually helps with your neutrophil adhesion to the endothelial cell wall. And then there's a lot of research where your von Willebrand can actually play a role in evasion of tumor cells. They've also shown no research that some of the tumor cells can actually advance in such stage that they can actually produce their own von Willebrand factors and evade the immune system. So because von Willebrand plays a role in prolonging your factor VIII level, that's usually important in the secondary hemostasis, but as well as in your primary hemostasis, forming a platelet plug. So these patients can present with mucocutaneous bleeding, epistaxis, bruising, or gum bleeding, and most commonly, women will present with menorrhagia. So this is just an animation of what the von Willebrand factor actually does. So it's a high multimer produced in continuously via endothelial cells, but it's also being broken down by the liver. So when it's activated, these high multimers actually unfolds and it binds to the endothelial cells as well as the platelets, forming a platelet plug. And this is what we need for a stable platelet plug to form. So the diagnosis of von Willebrand disease is actually based on the recognition that the normal von Willebrand function must be, first of all, present in adequate amounts. So this we can detect with just doing a von Willebrand factor antigen level, and to see also if it's present in normal multimeric structure. So for this, if you struggle with the diagnosis, we usually send our von Willebrand factors to Bloemfontein, where they do the multimer structure of these von Willebrand factors. And then also we want to see if the function is obtaining normal, sufficient binding sites. And this we usually will do with the ELISA method test. We will do the von Willebrand function test to see if it binds to glycoprotein 1b, as well as in Ampath, we can do the collagen binding test. So von Willebrand factor, the normal level is usually between 50% and 240. And it's also to remember that patients in blood group O usually present with less von Willebrand factor than other ABO blood groups. And this is due to the carbohydrate side chains on the red blood cells that actually prevents also the degradation or the breakdown of the von Willebrand factor. It's also important to know that von Willebrand factor also behaves as an acute phase reactant, and these levels can increase when a patient is under stress, trauma, or at an adrenal stimulation. Also, histamine reaction could also increase your von Willebrand factor. And it's very important to note this, that if you may be having a patient with a bleeding tendency, but has just now got an allergic reaction to something and you test for your von Willebrand, and it's just borderline high, you may be hiding type 1 because of the acute phase reactant. So in these patients, we would best to repeat the von Willebrand test when the patient is more relaxed or has got no adrenal stimulation. And the other part is von Willebrand factor also increases during pregnancy, and this is a protective mechanism that a woman will have in place to decrease the risk of bleeding. And it usually increases in the late trimester. So if you do have a type 1 and we test von Willebrand in your late trimester, you can also falsely miss a type 1. And this is the complex structure of von Willebrand factor. As you can see, I'm going to talk now about the classification of von Willebrand disease, but this is the structure with all the types of mutation you can get affecting the binding. So as you can see in R type 2A, the mutation will be in the 2A region, and this 2A region, and that's usually where ADAMTS13 cleaves the von Willebrand factor. There's also other areas where the mutation can occur, and this is just for interest sake if you do want to go back and assess for the structure of von Willebrand. So to just classify von Willebrand disease in a simple way, type 1 is just when you have a decreased amount of von Willebrand factor, and the function and the amount of von Willebrand factor is decreased proportionately. But in type 2, there's a functional defect. So that will say when we do the function over the antigen, there's a discrepancy in the ratio. So the antigen may be producing adequate amounts, but the function is not working. And usually in type 2A, it's usually when there's an impair in the large multimers of the von Willebrand factor. And as I showed to you in the picture, it's usually got to do with decrease in calcium binding. So if we do a von Willebrand calcium binding, it will actually lead us to help with the diagnosis of a type 2A. With a type 2B, the mutation occurred in the area where the von Willebrand actually needs to bind to glycoprotein 1B on the platelets. So this is hyperfunctional. So this von Willebrand just keeps on binding to platelets. And a type 2B will present with a slightly lower platelet count and also decreased von Willebrand factor because it's being used and consumed in the circulation. With type 2B, there's also a decrease in binding in your type 1B binding spot, but the multimer's size is not affected. And in type 2N, there's a decreased binding to factor 8. So these patients may present like a mild hemophilia because the von Willebrand can't bind and hold on to factor 5 or factor 8. Your factor 8 levels in these patients will be low. And in type 3, like I mentioned, you've got a decrease, almost absent production of von Willebrand factor, leading to also decrease in the binding of factor 8. So these patients will present with severe bleeding. And I'm not going to go through this. This is for completeness sake that I just tried to summarize the classification of von Willebrand disease in an easier type of way. But it's just to remember type 1 is just a decrease in production of the antigen. Type 2, the function is affected. This is very interesting because according to all the textbooks, type 1 von Willebrand disease is the most commonly diagnosed von Willebrand. But as you can see in recent studies, if you look at South Africa's table, you can see that the type 1 is actually not as commonly diagnosed, but more type 2. And this shows us that we should actually try and further investigate our patients in doing the function, because maybe we're misdiagnosing our patients in South Africa if we think that type 1 is the most common. And also interesting, if you see in Iran and India, type 3 that's supposed to be very rare is also quite increasing. So maybe they were misdiagnosing these patients because of the hospital care or the medical facilities in those areas. But this just shows you there's a lot of advance and research available in von Willebrand disease. So what do we do if somebody wants to assess for von Willebrand disease? So first of all, the patients will be complaining about bleeding, usually a woman with increased menstruation. So first of all, we're going to assess her bleeding symptoms. We're going to also find out if there's a family history of bleeding. And then very important, just do the basic bloods. Do a FBC just to assess the platelet count. We want to do a PT and PTT just to assess for coagulation factors as well as the fibrinogen, just to make sure that we're not missing something underlyingly. And then the first test to screen for von Willebrand disease will be these 4 panel tests. Most of the labs will only offer a 3-panel test. That will be the antigen, just to see the amount of von Willebrand factor you're producing. Then they'll also do the activity, just to see how much von Willebrand factor is actually binding to your platelets. And then factor 8 level that most of the labs will be doing. And then at Ampath, we implemented the laser collagen binding. And this is just to decrease false diagnosis, or actually just to confirm the diagnosis. And then second level tests. These tests are usually done at Bloemfontein, where you can assess for further subclassification of the type of von Willebrand disease. So your von Willebrand subtype 2N, this is when you don't bind to factor 8. So a few months ago, our lab inquired Bloemfontein if they actually do have these tests available, and they stopped doing it. And it's because they've never diagnosed the type 2N in their lab. So with this, you'll actually just do your factor 8 level, and then if it's very proportionately low to your von Willebrand factor, you'll assume that it will be a type 2N. The multimer analysis we'll have to send away to Bloemfontein, and they'll confirm if we suspected a 2A or a 2B. Low-dose ristocetin-induced platelet aggregation, what this is just a platelet aggregometry with a low-dose ristocetin. So that all the labs can do to assess, and this we will do to assess type 2B. And then the von Willebrand pro-peptide assays, just to see if your type 1 von Willebrand is actually caused by decreased production or an increase in breakdown or clearance of the von Willebrand. And I know this is also being done in Bloemfontein. This is not done in our lab. We will offer the aggregation and the first 4 steps. So, to assess for von Willebrand, they usually suggest to use a standardized bleeding assessment tool. And this will just help you with the decision if the patient will have a risk of bleeding or the grade of the bleeding, to see if it's going to help you to assess. But first of all, this is a bleeding assessment score from the ISTH. So it could be very complicated. And the thing is, if your score is less than 2, it's very unlikely for you to have a bleeding disorder. But then again, if you're a male and you're an adult male and you've got more than 4, you've got a risk. If you're a female, a count of more than 6. So for me, this is quite labor intensive, and I think patient variability will affect it, doctor variabilities. So I think if you do have a patient complaining of bruising, menorrhagia, there's no harm if finances is available to just do a von Willebrand screen. So what we need for von Willebrand is just a citrate tube. What we do in the lab when we receive the citrate tube is we centrifuge the specimen, and this is just to make sure that the platelets won't activate the von Willebrand factor in your plasma. And we need to store it at 2 to 8 degrees for 4 hours, if longer at minus 40 degrees. The reason for this is if your sample maybe froze during the transport system, it will affect your von Willebrand factor levels, because the von Willebrand is a very large molecule. It will precipitate and will give you false results. So that's why it's very important to transport it correctly, and also very that I also explained, if you do have a patient that you've worried, rather send them closer to the lab, let them draw the blood, and we can assess for it. So this I know is going to bore you. I'm going to go quickly through it, but this is just the principle of the test. So for the antigen, von Willebrand antigen, we just want to make sure how much von Willebrand is the patient being produced, and we use an ELISA assay. Most of the ELISA assays work on this principle, where they use actually just a latex assay that has got microparticles coated with the von Willebrand antigen. And then there's a antibody that will bind to the von Willebrand factor and bind to this latex antigens, and we can actually detect it proportionally with the degree of agglutination. And this is the same principle that they use for the propeptide assay, the collagen binding, as well as the factor VIII binding assay. So this is just to see how many of the factor level is in your blood. With the von Willebrand activity assay in our lab, we make use of the fact that von Willebrand binds to its receptor 1b on platelets. So we use polystyrene particles that are also coated against the glycoprotein 1b. And because this glycoprotein B has got a recombinant gain of function mutation, it is added, and then the antibody will actually cause the von Willebrand to bind to it. And because it's got a gain of function mutation, we do not need to add ristocetin. Previously, they'll use ristocetin to activate these platelets to bind, but we don't use it because it could cause variability in the lab results. And then we just measure the binding to see the function of the von Willebrand factor. And then ristocetin-induced platelet aggregation, like I mentioned, this is just a platelet aggregometry test. And they use it for electron emission aggregometry. And in a normal, we'll just use a normal percentage of ristocetin, and we'll see the agglutination. And then we'll also use actually a less concentration to see if there's increased binding. And then in a decreased concentration, we'll actually just also increase the amount of ristocetin. And this is just also for interest sake. We don't do it. This is done in Bloemfontein, but what they do is usually we'll send all von Willebrands that got an abnormal results to von Willebrand to Bloemfontein for confirmation of the multimer structure. And all that they do is it's actually an agarose gel electrophoresis. And what it is, it's just electrophoresis on gel plate, the size of the von Willebrand factor. And as you can see, the larger molecule will move slower, so it will be on top. Intermediate molecules will be in the middle, and if you've got very low molecule or size molecules, it will be at the end. And this is how they actually use to diagnose this, because a type 1, as I mentioned, it's got a normal multimers pattern, but remember they've got a decreased amount in being produced. So as you can see in the column 1, I don't have my index thing, it's just a lighter density, but the function or the structure is normal. And in type 3, as you can see in the line 6, there's almost no von Willebrand factor being produced. And in type 2A, there's absence of your large and intermediate multimers. So type 2A needs to bind to collagen, and this we actually detect and we can confirm if there's absence of large or intermediate multimers. Type 2B, where there's an increase to the glycoprotein 1b on platelets, they usually also present with absence of large multimers. And type 2M, they usually have normal multimers, and type 2N abnormal multimers. So as you can see in our workup, we'll actually go with elimination of what type the von Willebrand will be. And this is just the way that we will actually assess von Willebrand. So we'll start with the von Willebrand antigen. If it's like totally absent, very low, you could say 1 to 5, it's most likely going to be a type 3. Then we'll move on. If we see that we do have an antigen function, we'll do the antigen level, we'll do the function. And if the function over the antigen ratio is proportionate, so this will just say that there's a low amount of von Willebrand being produced, it's most likely type 1. And then we can actually also send away for propeptide with the antigen. And if we see that that's increased, it will usually be a type 1 due to increased clearance. Usually the type 2Ns do also have a proportionate ratio of function over antigen, but we will also detect that our factor 8 level is discrepant according to the antigen present. And usually if your factor 8 is less than 20% or very low, this is suggestive of a type 2N. And now if we do have a discrepant ratio where our function over our antigen is less than 0.7, we will move to a type 2. And what we do at our lab, we'll then do the collagen binding over our antigen ratio. And if that is proportionate, it's most likely a type 2M or type 2N. So usually we can then discriminate type 2N here because if you've got a normal factor 8 level, it will most likely be type 2M. If we've got a discrepant ratio, because we know the collagen binding is needed in large and intermediate multimers, it will lead to a type 2A and a type 2B. But type 2B, we can actually diagnose in the lab with doing the platelet aggregometry, and there will be an increased binding due to decreased dose resuscitin. So we can actually then eliminate our diagnosis like that. And like I mentioned, and also there's a very rare defect where there's a Sefako von Willebrand, where there's actually just the platelets of the patient has got an increased binding to the von Willebrand, and that we can actually just do with our resuscitin-induced platelet mixing studies, and it will eliminate this disease. But it's also very rare, but we can do it. So as you can see, von Willebrand is quite interesting or intriguing, but if you do keep your head and you just follow a flow diagram, you can actually lead to a diagnosis. And that flow diagram is just summarized a bit easier in this one. So it's also just for you guys for reference. And then another interesting thing about von Willebrand. So it's the most common inherited disorder, but you can also acquire von Willebrand disease. So acquired von Willebrand disease, when will you actually suspect this? So this will be an older type of patient. With age is not actually that important, but it will be a patient that's got no family history of a bleeding disorder. Previously in his life, he had no problems with a bleeding disorder. And now all of a sudden he's maybe sick, being diagnosed with another malignancy or with multiple myeloma, actually also a patient with hypothyroidism. And now when we actually did the von Willebrand screen, we detected it's abnormal. So this patient actually detected or acquired or got an acquired von Willebrand disease. And this is caused by multiple factors. It could be due to increased clearance of the von Willebrand. It could be due to decreased production. That's the cause of hypothyroidism. And then also if the patient has aortic stenosis, the von Willebrand factor can actually be broken down by the stenosis, and then the system will actually absorb all the activated von Willebrand. And the patient will then present with a bleeding sign because there's no von Willebrand binding on factor 8. And this is now not projecting. There's also multiple myeloma, and then myeloproliferative neoplasms are quite common. And this is because the platelet counts are very high, binding to the von Willebrand, leading to destruction of your von Willebrand factor. Immune disorders could also present in acquired von Willebrand. And then, like I said, hypothyroidism is one just to remember. And then another interesting thing is there's also some drugs and other agents that can lead to acquired von Willebrand, like valproic acid, as well as ciprofloxacin. And now the treatment of von Willebrand that I'm just going to touch on. So for type 1, it's most likely going to be desmopressin. Desmopressin is an antidiuretic hormone that usually increases the release of von Willebrand factors. In type 1, this would be efficient. It will increase your von Willebrand to a state where the patient will actually stop bleeding. Because of desmopressin, it's usually best advised to do a trial in this patient. So you'll see how they respond. You usually want the von Willebrand factor to go up above 50 in the patient's level, and this is usually needed before a surgery if you know that the patient is going for surgery. It's also important to know that desmopressin has got other side effects because hyponatremia, so you do not want to give this in too old patients. As well as patients with cardiac disease, get the increased risk of thrombosis. And then also know that you get tachyphylaxis in this patient where they actually decrease a response to the desmopressin. And then you can also actually replace your von Willebrand through plasma concentrates, plasma-derived concentrates. There's also new recombinant von Willebrand factors that they produce. The cryoprecipitate that's usually high in von Willebrand, factor 8, and fibrinogen. And then you can use fresh frozen plasma in a patient that is bleeding. And then also you can use adjuvant therapies like fibrin glue or tranexamic acid. And another important thing, oral contraceptions with the estrogen will also increase the von Willebrand. So it's an option in the younger patient bleeding. At the end, you can also use a platelet transfusion. So this is just the treatment with the dosage recommended there. If you guys want to read through it, it's also just very important to note that with the recent research that with the recombinant von Willebrand factor, it's actually made of Chinese hamster ovary cells, and they contain also trace amounts of factor 8. And what's nice of this is these products are also high molecular weight molecules, and they're not being broken down by the patient's own ADAM TS13. So it's one of the advantages. And okay, so this is not very nicely projected on my screen at ease, but this is just for the acquired von Willebrand disease, all the different types of treatment. If you do have an immune deficiency or autoimmune disease, you can also give IV immunoglobulin as well as plasmapheresis to assist in the treatment. But to remember, with acquired von Willebrand disease, if you treat the cause, you would resolve the von Willebrand, the acquired von Willebrand disease. So that was in a nutshell von Willebrand disease. I know it's a bit intriguing and it's difficult to diagnose if you're not 100% sure, but I think that's why we at the lab is there available to try assist and help with the diagnosis. And that was von Willebrand summarized in a very short presentation, and there's all my references for needed.
Thank you, Michelle, for the in-depth presentations. And yeah, I think what's clear is that there's no substitute for thinking. You have to think about it because it's not really a straightforward diagnosis, and it's not neither is a clinical diagnosis. So you will see a patient coming with thrombocytopenia, and you kind of have to think about it. As he mentioned already, you have two types. You have the acquired, and you have the hereditary type. Obviously, I think the age probably play a role in the hereditary compared to the acquired. But also, acquired, the patient will have other comorbidity. So you kind of have to think about it, and you might have to probably, do your first profile clinically. And if your test marks are not, the test does not add up, then you really have to request for the von Willebrand factor, or just discuss with your hematologist. And most of your hematologists, actually, they might call you before, actually. So it's really, I think, for the students, it's really about our approach to thrombocytopenia and obvious patient with bleeding disorder. And then this is how you approach them. Yeah, so I think this is quite good in their presentations. And so I think probably it's worthwhile to listen to it. It's not really as laboratory as you'd say it. It's actually got a lot of clinical aspect to it. Yeah, so thank you for that.
And I think just one thing that I want to emphasize on, usually we get, I'm just going to use an example. I got a blood result from a lady bruising from Bella, and I drew the blood, and we could see the von Willebrand factor and antigen level is borderline, and the factor 8 level was low. It's very, very important to know pre-analytical variables could affect it. And even though, it's also quite expensive to investigate these tests. Like what I wanted to say, I just want to show you guys the prices. So just the factor 8 level alone costs about 730 Rand. The activity is 805. And then the antigen is 1,370. So if you do a screen, it works about 5,000 Rand out for the patient. So it's quite nice to communicate with the doctor, draw it, separate, inform the lab, put it on ice, arrange with the lab, because you don't want a sample that's been lying somewhere, and now we have to do von Willebrand, and we see it's borderline low. Then when we repeat it, the patient was near the lab, it's normal. So you don't want to falsely diagnose a patient. Because pre-analytic variables is very important with von Willebrand. And also remember, factor 8 is a liable factor, and platelets activate your von Willebrand, and then it will eat up or consume your factor 8. So it's very important if you do tests for this, just to arrange with the lab, arrange with the doctor. Not that you have to repeat it, but just to make confirmation. Because with this Bella patient, I had to ask for repeat. And, because these patients have to pay for it, it's actually something you want to avoid. But you'll have to confirm if it's wishy-washy, confirm and repeat the test, unfortunately.
But I think also it's not about the cost, about the time consuming, because patients from far, and, there's transport involved. There are a lot of other issues involved. And I think the reason we're really having this presentation is to bridge that gap between the clinicians and also our lab expert. So at least there's kind of direct communications, and then you can kind of get the support you need. And if you're not so sure, it's always nice to pick up the number or just call the labs, and then the labs will advise you, and they'll actually give you guidance about the diagnosis and also what could be, what could not, because they have opportunity. I mean, they have privilege of looking into the slide, looking at the cell type, and look at what might be. So I think it's always nice that we must have that communication ongoing between us and our colleagues. And that's why medicine is not a single one-person game, but it's really more kind of multidisciplinary, and we kind of have to work together. For now, any good news? No. Holiday. Amik? Any comment of?
Well, I wanted to ask, in South Africa, does anyone test for platelet type on Willebrand's disease?
I've never had a diagnosis. I've only seen, as a register also where they explained to us how did we can test it. But I need to go and look for references to see, because all the journals are they just say it's different. If it's quite common.
What is the competitive recon mixing studies or special type of flow cytometry with infant to do a mixing study?
No, I think we can, and I think actually probably to do things like mixing. You just like the patient. I think we will be.
So, technically possible.
Yes.
Dr. Okoli, are you online? I know generator is working against us. The people online. Any other, Dr. Okoli?
Yes, Doc.
Any question? You're in Secunda alone, obviously there, and you might need a bit of, basically we have a lot of hematologists here. If you have any problem, you must just let me know. I'll send you the numbers. Ampath is one of our dominant lab there. Do you have any question?
No, I don't have any question, Doc. Yeah, the Ampath team, they are very supportive here as well.
Yeah. Okay. Dr. Godinho, are we awake?
Thank you very much for the presentation. Appreciate it.
Yeah.
Yes, can you hear me?
Thank you, everybody. We appreciate it. And yeah, let's hope, I think probably I don't know whether we have a new other presentation, but we appreciate you guys coming online. Have a super lovely day. Michelle, thank you for presentation. And probably see you guys next year. Bye-bye.